All right, so we're going to talk about bariatric surgery today. I know the title of this talk says bariatric operations, but I figured we'd talk more about outcomes and the plus side of bariatric surgery rather than complications like we typically address. So we're going to look beyond the readmissions for PO intolerance that occur fairly frequently and talk about the good stuff. So I have no disclosures. So our objective, I'm gonna go quickly through the most commonly performed bariatric procedures and then discuss the expected weight loss outcomes in the short term and long term based on some studies, some recent studies we've had come out, and also discuss indications for bariatric surgery and the expected resolution of comorbidities. I'm gonna focus mostly on diabetes, but we'll talk a little bit about some of the other parts of metabolic syndrome too. So obesity is one of the most common major public health concerns besides COVID right now. It's associated with multiple other comorbidities, as you can see there, hypertension, diabetes, hyperlipidemia, even infertility and heart disease, all sorts of stuff. So it really plays a role in our health throughout. Our definition broadly, BMI greater than 40 is morbid obesity. Class 1 and 2 are within the 30s, and then overweight is a BMI of 21 or greater. You can see our normal classifications there. The prevalence of obesity is going up. The dotted lines are women. The more solid lines are men. You can see that over the years, as late as 2018, there's increasing rates of obesity within the United States. So this is all from the CDC. We're based on these projections, by 2030, about 50% of the United States population are projected to be obese. So the green lines are, I think, the class 1, class 2 obesity. I think it's all lumped together there. And then severe obesity would be obviously BMI greater than 40. All right, so who's eligible for bariatric surgery? So most people, we know this. BMI of 35 or greater with comorbid conditions, BMI of greater than 40 without comorbid conditions. And then they also have to have an inability to achieve weight loss with medical means or weight loss on their own. There's some of the ASMBS and society has come out with statements saying that, or an opinion statement saying that patients who are Asian and have BMI greater than 30 should qualify. And there's also talk of making diabetes, a BMI greater than 30 and diabetes a criteria, but I think that's still kind of in the works or still controversial. So I'm going to talk about these 5 procedures, kind of the most common ones. Obviously, the Roux-en-Y gastric bypass and sleeve gastrectomy are the 2 most commonly performed here and in most centers. The adjustable gastric band used to be very popular and has kind of fallen out of favor due to complications and poor overall outcomes. The duodenal switch or biliopancreatic diversion was popularized back in the day and mostly used as a weight loss procedure for patients with BMI greater than 60, so the severely morbidly obese, and oftentimes is done in a staged procedure, so we'll talk about that. And then a new procedure that's kind of come out in the last few years, the single anastomosis duodenal ileal bypass with the sleeve gastrectomy. It's kind of modeled after the duodenal switch, but a little bit easier to perform. And supposedly the outcomes are better, although there's not really a lot of studies comparing outcomes yet with that. But we have started, I think Tim Schaffner has done one here so far. And I think we have like 2 or more on the schedule, that last procedure. So bariatric surgery numbers, you can see becoming more and more popular. 256,000 procedures performed within the United States on a yearly basis. So that's a lot of bariatric procedures. You can see how the trends have changed from where band and bypass were the most common procedures performed. And now the sleeve gastrectomy has kind of taken over and the band has kind of fallen out of favor. Gastric bypass has slightly decreased with the incline in sleeve gastrectomy, but I suspect with the studies coming out increasing reflux rates that the gastric bypass is going to start to rise again and sleeve is going to start to go up again in the next few years. We don't have data out to 2021, but I suspect that's starting to change as we speak. So the first procedure, gastric bypass, you can see it's a malabsorptive and restrictive procedure. So we restrict the size of the gastric pouch to about 30 cc's. And then we measure out our biliopancreatic limb, it's about 50 centimeters. And then our roux limb ends up being about 100 centimeters, 100 to 150 centimeters. And then we make our distal anastomosis, so leaving a long common channel. So that's where you get your malabsorption. So it's in general the gastric bypass. Sleeve gastrectomy, we remove about 80% of the stomach. It's a restriction only procedure. And so the size of the sleeve ends up being about 4 ounces or so. And much more, there's no malabsorptive components to that at all. The lap adjustable gastric band. So we put a silastic band around the proximal stomach, and that restricts the size of, or the amount the patients can eat. The band is adjustable. So there's a port where you can inject fluid into it to make the restriction greater or less. I have never put one of these in, and take a lot of them out, mostly for slippage of the proximal stomach above the band or slippage of the band, complications, also reflux issues. But that's that. Some of the studies we'll talk about includes the gastric band in them though. This is the biliopancreatic diversion with duodenal switch. So you can see you create a sleeve gastrectomy essentially in the stomach. And it can be done as a staged procedure. So patients with a really high BMI, you can start out with a sleeve, get them down to a more manageable weight, and then perform the duodenal or the malabsorptive component of the procedure. So you divide the stomach just beyond the pylorus, and then connect the ileum. So the common tissue in this procedure, you measure from the ileocecal valve. And I think initially they had like very short common channels, like even 100 to 200. We've then lengthened that because of problems with nutritional deficiencies and protein deficiencies. And so this procedure's sort of fallen out of favor because of the higher complication risk with nutritional deficiencies. This is the one of the newer procedures, so single anastomosis. So you can see that instead of having the 2 anastomoses, you now only have the 1, and it's kind of set up more like a Billroth type procedure. So still do the sleeve first, but then the alimentary or common channel is 200, 300 centimeters. I think most people are doing longer common channels. And then you basically connect it to the first portion of the duodenum. Okay. All right, overall mortality rate, these are numbers from the ASMBS, is 0.1%, and complication rate is approximately 4%. So that puts that on par with gallbladder surgery, hip replacement surgery, other common surgeries we do. Outcomes, so we're gonna talk about these in detail: weight loss, short and long term, and then clearly demonstrated, there's been many studies clearly demonstrating metabolic benefits over medical management of multiple comorbidities. Those are just a few of them. We're going to go into detail on diabetes and then include some data on hypertension, hyperlipidemia, and as well. So bariatric surgery, there's been lots of statements that have come out from both the American Heart Association, diabetes, the endocrinology associations, stating their agreement with bariatric surgery as a primary treatment for metabolic disorders. Oops. All right, so this is published by the ASMBS, but we're going to talk about specific studies and where these numbers come from. So percent resolved or improved, so that's off medications, or resolved is off medications completely. And then there's criteria for remission. So I think the criteria is less, hemoglobin A1C less than 6.5% for greater than 1 year off medications. And then hypertension, off medications, or at least decreased medications, obstructive sleep apnea, and I don't remember the exact criteria for that. And then hyperlipidemia, off medications or at least reduce medications. Okay, weight loss obviously is highly variable. And trials have generally shown the biliary-pancreatic diversion to have slightly better weight loss than the gastric bypass. There's a couple randomized control trials that we'll talk about comparing the Roux-en-Y gastric bypass to the sleeve, which have found a general trend of Roux-en-Y gastric bypass having slightly better weight loss, but really haven't shown a statistically significant difference. And then both of those procedures better than the laparoscopic adjustable gastric band. So there's comparing a lot of these studies is difficult because they a lot of them define their weight loss differently. So some of the studies will define it as total weight loss. Some will define it as percentage change in excess body weight or excess BMI. So they a lot of the studies have different endpoints in terms of weight loss. So they've had trouble standardizing the outcomes in terms of weight loss. So this is a study that was done in Switzerland called the Anastomosis trial, compared laparoscopic sleeve gastrectomy with Roux-en-Y gastric bypass. They evaluated out of 4 centers, almost 4,000 patients and enrolled 217. They had exclusion criteria of GERD, hiatal hernia, presumably because they didn't want to do a sleeve gastrectomy in anyone who had GERD or a huge hiatal hernia. And then major abdominal surgery, previous abdominal surgery, so excluded quite a few people. 217 enrolled. Their primary endpoint was weight loss, and they found no significant difference at 1, 2, or 5 years. I think the P, I must not have put it up there, I think it was like 0.22. But they did note a trend towards greater weight loss in the bypass at 68% at 5 years and 61%, and this is of excess body weight. Or excess BMI loss, sorry. And then they also had some secondary endpoints that we'll talk about a little bit later when we talk more about hypertension, hyperlipidemia, and stuff like that. They did note that gastric reflux remission was observed more frequently after gastric bypass rather than after sleeve gastrectomy, and often worsened in sleeve gastrectomy. So pretty high reflux rates of 31% in the sleeve gastrectomy. Those reoperation rates at the bottom of the slide, one was for sleeve gastrectomy, most of those were for reflux. The gastric bypass, most of the reoperations were for internal hernia. Okay, and there's varying methods. It's about half of them, they didn't close the defect for the internal hernia, and the other half, the defects were closed. This is another study, came out the next year in Finland. Similarly set up, 240 patients with morbid obesity. They had slightly different inclusion criteria, slightly younger age, so 18 to 60 instead of 18 to 65 in the last one. They had similar exclusion criteria and similar outcomes, so slightly better. They did excess weight loss, so different instead of excess BMI, so it's slightly different endpoints. 49% after sleeve gastrectomy, 57% after gastric bypass. These numbers are at 5 years, and they did not find a statistical significance, but obviously a trend towards a difference there.
When they say excess weight loss, what's the percentage? What does that mean?
So everybody calculates it different. In this study, they basically used ideal body weight. So they do their baseline weight before.
That's the mean percentage excess weight loss?
Yeah, exactly. So it's based on their ideal body weight. Some other studies will do comparing their weight to just their baseline weight, so their actual weight. So it's all kind of wonky the way everybody does it differently. But yeah, in this study, that was exactly, they used ideal body weight comparison. So we talked about these results. In observational studies, they found that gastric bypasses generally achieve greater weight loss, approximately 6%, that's excess body weight. Total body weight. Okay, so durability, so we know they have weight loss within the short term, within 5 years, but what about longer? So this is a meta-analysis, and I think there was in the range of 30-some thousand, so I don't remember exactly how many patients, but multiple studies, and they found these are the numbers for the excess weight loss. So these excess body weight in these studies or in this meta-analysis, and they somehow standardized or normalized all the numbers. But you can see that Roux-en-Y gastric bypass has the most studies with the excess weight loss of 57% about. Sleeve gastrectomy was found to be equivalent in the study, but there was only 2 studies that included sleeve gastrectomy, and the numbers were very, very low. So I don't know how you can, so you got to take that with a grain of salt. Pancreatic diversion obviously has had higher weight loss, and that's been proven in multiple studies. So 10-year weight regain, this was in a study in JAMA in 2016. So that's weight regain to within 5% of their preoperative weight. So the percentage that happens in sleeve gastrectomy is 12 to 14.5%. Roux-en-Y gastric bypass, much lower percentage. In the lap adjustable gastric band, they found 30 to 36%. So overall weight regain, low rates, fairly good maintenance over 10 years. So this is another cohort study. It's retrospective. There was like 32,000 patients. They measured total weight loss at 1, 3, and 5 years. So the 5-year mean in Roux-en-Y gastric bypass was 25%. So we're talking total body weight loss in this instance. That's why the numbers are so different. And then sleeve gastrectomy, 18.8%. And that did meet statistical significance. They found for patients with diabetes, BMI less than 50, age greater than 65, African American or Hispanic heritage lost less weight. So, and we see that often in clinical practice. So what are the metabolic effects? Now we're going to talk about resolution of diabetes mostly, but also some of the other comorbidities that go along with it. So metabolic syndrome defined as a co-occurrence of metabolic risk factors for both diabetes, type 2 diabetes and cardiovascular disease. So as you can imagine, if you lower all the factors that go into cardiovascular disease, you lower your risk of cardiovascular or cardiovascular outcomes. So type 2 diabetes is important because 85% of diabetics are obese, and bariatric surgery, we've demonstrated in multiple studies that it has is the most effective treatment for diabetic patients over medical management. This is just a review out of the Cleveland Clinic that came out a few years back. Just advertising that the American Diabetes Association essentially has agreed with us that bariatric surgery is effective in treatment of type 2 diabetes. All right, so these are some, we'll go through a little bit of the medical therapy. So there's been multiple randomized control trials that defined, we talked about the remission as a hemoglobin A1C less than 6.5% without medications for greater than 1 year. And all but one of these studies found surgery to be superior to medical therapy. On average, they found a decrease in their hemoglobin A1C from 2 to 3.5% in the surgical groups, and 1 to 1.5% in the medical group. So medical management of diabetes, they defined as obviously oral hypoglycemics, insulin use, and then lifestyle modifications, including diet, exercise, etc. So this is another prospective longitudinal studies. They studied 28,000 obese patients, and after sleeve gastrectomy, well, they examined sleeve, band, and bypass, so various bariatric procedures, and they saw remission or improvement at 12 months in 83% of the Roux-en-Y gastric bypasses, 55 for sleeve gastrectomy, and 44 for laparoscopic adjustable gastric band. Some longer outcomes, so durability. So this is mostly talks about Roux-en-Y gastric bypass and compares it to Lapans. So this was back in 2011, or most of the data was collected in the early 2000s, and then it was just published in 2018, but can't remember the exact dates that their data collection took place, but it was earlier when bands were more popular. So they found remission rates for diabetes at 1, 3, 5, and 7 years. And you can see that it does trend downward, but overall, pretty good results, especially in the gastric bypass. And that makes sense just because of the hormonal effects that you get from gastric bypass. Presumably, most of the weight or the changes in diabetes from the lap adjustable gastric band has to do with weight loss, because they found that that the outcomes kind of dragged out in the lap adjustable gastric band, so they didn't have as an immediate response to or immediate lowering of fasting blood sugars. Whereas in the gastric bypass, it's pretty prominent within the first few days after surgery. All right, this is a study that just came out in the Lancet 2021, compared metabolic surgery versus conventional medical therapy. And it was a randomized controlled trial in Italy, I believe. They have 60 patients only, non-blinded. But they compared basically because they didn't blind them, because I guess the surgeon who did the biliopancreatic diversions operated open, and the Roux-en-Y operated laparoscopically. So that was impossible. They had a pretty good 10-year follow-up of 95%. You can see their demographics there. Their criteria for inclusion, they had to have type 2 diabetes requiring medications for greater than 5 years, and hemoglobin A1C greater than 7. So that you can see their exclusion criteria. And overall remission rates at 10 years was 50% in the biliopancreatic diversion, 25% in the Roux-en-Y gastric bypass, and 0% in the medical therapy group. All of them had a hemoglobin A1C less than 6.7%. So overall, adequate control of diabetes. Even those patients were on some medications though, so not completely off oral hypoglycemics. So the Sleeve Pass trial, that was the second one we talked about from Finland. These are some of the numbers of, we talked about the diabetes resolution that they found, and then also hyperlipidemia and hypertension. The only one that reached statistical significance comparing the gastric bypass to sleeve was for hypertension. And these numbers are actually really comparable to the other SM-BOSS trial that was in Switzerland. They're almost very, very similar. And same story, they reached significance in hypertension only. Hyperlipidemia was very close though. And I think that is it.